Hello everybody. I'm honored to be here with you in my second country in Libya. And I would like to discuss with you today a very important issue about the shoulder, which is a slab lesion. Slab lesion simply is a tear occurred in the superior labrum. And the superior labrum is very important as it is the attachment of the long head of the biceps. So when you find a tear from the anterior to posterior in the superior labrum, that means it's a slab lesion. Okay? A slab lesion occurs and demonstrates a predilection for young workers and overhead athletes. What is the etiology of the slab lesion? The first etiology and the first cause is the acute traumatic occurrences which occurs in the laborers and sorry, not working. Okay. The acute traumatic slab lesions occur in three forms, and maybe compression type injuries which occur in over an outstretched arm, when the patient falls on outstretched arm with varying degree of shoulder abduction, or a traction type injury occurs while lifting heavy objects, or a combined type injury between the compression and the traction type. The second mechanism is the peel back mechanism. What is the peel back mechanism? It is simply abduction and external rotation makes the slab happens. Mainly you can see that in the throwing sports like throwing a ball, or in the stage of arm cooking in these athletes. The degenerative slab lesion is the third type. Actually, you see that in many cases, like rotator cuff tears, as the professor has discussed before. In 1985, Andrews first described the superior labral pathology. In 1990, Snyder coined the term slab lesion because of the location and characteristic tear extension patterns. In 1998, Morgan et al. Further subdivided slab classification to 10 different types of slab tear pattern, including combined slab and banker type injuries seen in specific associated patterns. What are the slab types? The first type is the degenerative, which changes the superior labrum. The second type is the tear in the biceps anchor detachment. The third type is the bucket handle tear of the superior labrum with an intact biceps anchor. Bucket handle tear is the fourth type with biceps tendon anchor is torn or involved. This is the difference between the third type and the fourth type is the biceps anchor. In the third type, the biceps anchor is intact, but in the fourth type, it is involved or torn. The type 5, extension of banker lesion with involvement of the superior labrum and biceps anchor, or a slab lesion with anterior inferior extension. Slab 6, anterior to posterior flap tear, similar to slab type 4 and 3 with a bucket handle component. Slab 7, extension of a slab lesion into the glenohumeral ligament. Slab 8, extension of a slab lesion into the posterior labrum and further abnormality. Type 10, type 9, circumferential labral detachment. And type 10, extension of the rotator cuff interval and antegrade-sided abnormality. Actually, the main types, the first, second, third, and fourth. The other types, or the subdivided types from 5 to 10, are subdivisions from the first 4 types of the slab lesion. This is another emphasis to which we have said about. And you can see here the difference between slab 1, slab 2, slab 3, and slab 4. And you can see here the difference between slab 3 and slab 4, where the biceps anchor is intact in slab 3, and detached in slab 4. What is the clinical presentation? First, is a multifactorial and remain a topic of debate and controversy. Patient presenting with bobbing, locking, catching with various movements and deep shoulder pain. What is the symptoms? Mechanical symptoms, bobbing, locking, catching with various movements. History of any sudden jerky force of the shoulder with an associated onset of pain. History of current episodes of shoulder instability. History of sports like overhead sports, throwing, volleyball, swimming, baseball pitchers. History of current manual workers. What is the physical examination? Start with cervical examination. The coexisting cervical radiolopathy should be ruled out in any situation where neck and or shoulder pathology is a consideration. Observation of a neck position, muscular symmetry, palpable tenderness, and active or passive movement should undergo evaluation. Special tests that are helpful in this regards, including sparing maneuver, myelopathic testing, and comprehensive neurovascular examination. The shoulder examination, starting with looking at the shoulder, compare both shoulders for asymmetry, scapular posture, atrophic changes, skin for previous operations, active and passive range of motion are both documented. Specific testing of shoulder can be difficult when passive range is limited. When the patient comes with you with a frozen shoulder, you cannot do the shoulder examination. Neurological deficit, you should exclude axillary nerve or brachial plexus injury. There is other provocative tests, but no physical examination maneuver is highly sensitive and specific for slab pathology. First, the biceps provocation test, speed test, Yerkson test, slab lesion test, specific slab lesion tests like active compression O'Brien's test, supine flexion resistance test, and dynamic labral shear test. The Yerkson test is a very common test. When the patient comes with to be examined, the patient will fix his arm in the waist and the elbow is flexed 90 degrees and he do pronation and then he resists your supination mobility. When the patient feels pain in the bicipital groove, deep in the biceps, this means that the test is positive. And the speed test, actually the patient stands in front of you and he do active elevation of the arm while the arm facing upward, or the hand facing upward, and then he pushes upward. When the pain elicits, that means it is a positive test. Not working? This is the speed test. The patient pushes upward while you resist the movement to downward. Next. Okay. This is the Erickson test. The patient fixes in the waist, do pronation, and then resist your supination. You resist his supination. And the pain comes from the bicipital groove. While you do external rotation, that means it's a positive test. Next. The O'Brien test. The patient stands while the arm is in 90 degrees of forward flexion, 10 degrees of abduction, and internally rotated, so the thumb point is downward. And then he do upward elevation of the shoulder. And then he do external rotation or supination. When the pain elicits from the bicipital groove, this means this is positive test. Okay. Supine flexion resistance. The patient lies supine on the examination table while the arm is fully elevated over the head. And then your palm is above the arm and the patient pushes upward. Like that. And the patient pushes forward. When the patient comes from the bicipital groove, this means it's a positive test. Mayo shear test or Driscoll test. The patient stands with his or her involved arm flexed 90 degrees at the elbow and abducts the shoulder in the scapular plane to above 90 degrees. The examiner then applies terminal external rotation until resistance is appreciated. Next, the examiner applies a shear force through the shoulder joint by maintaining external rotation and horizontal abduction and lowering the arm from 120 to 60 degree abduction. A positive test include a reproduction of the pain or a painful click or catch in the joint line along the posterior joint line between 120 and 90 degree of abduction. Okay. Elevated in the scapular plane, 120 to 60, while you're making a shear force. When the patient feel click or pain, that means it's a positive test. What are the radiographic evaluation? X-ray, you do an AB X-ray for the glenohumeral joint and axillary lateral view and scapular Y. But the rule of the X-ray is limited. But you can know what are other associated problems with the slab lesion. Maybe fracture, maybe other thing, but the X-ray cannot alone diagnose the finding of a slab lesion. The MRI is a commonly used imaging modality to detect the slab lesion, intra-articular contract media, and articular effusion, as well as arm traction and external rotation improve the sensitivity of the MRI to determine a slab lesion. Here you see the slab type 1. As the arrow here, the signal goes below the superior labrum. This type 2, where the space is widened and you can see the labrum going downward and the signal comes below the labrum. This is slab 3, where the biceps origin is intact, but the tear comes below the long head of the biceps. What is the management? Non-operative management, anti-inflammatory medications, cryotherapy, cooling or ice application, rest and activity, physical therapy mainly to the scapulothoracic dyskinesia. And if non-operative therapy fails and symptoms persist that prevents sports activity or activities of daily living, then this will indicate the need for operative treatment. What is the operative management? Surgical treatment algorithms depending on specific types of slab lesion, identified and advanced imaging, clinical examination, and intraoperative arthroscopy. It is critical to discern whether the labrum alone is responsible for patient's symptoms and whether restoring the labrum attachment and biceps root to the glenoid will help. How to treat slab tear in the setting of other concomitant injury is imperative. In slab type 1, arthroscopic debridement is more than enough. In slab type 2, you should repair the slab or do tenotomy or tenodesis according to the age of the patient. In slab 3, the repair versus resection and tenodesis or tenotomy. Slab 4, if it is less than 50% of the biceps tendon is affected, slab repair or resection. If more than 50% of the biceps tendon is affected, tenotomy or tenodesis. Slab type 5, you slab repair, you make a slab repair or Bankert repair or slab and Bankert repair. If the patient is younger, you do the slab repair. If it's old, you do Bankert repair and tenodesis. In slab 6, slab repair versus resection. Slab 7, slab repair and anchor fixation of the anterosuperior labrum. Slab 8, the slab repair versus biceps tenotomy or tenodesis. Slab 1, conservative therapy versus debridement. Slab 2, if the patient is young, do slab repair. if the patient is slab 2, if the patient is old, you do tenotomy or tenodesis according the activity and the age of the patient. Slab 3, resection of the bucket handle tear. In slab 4, if the patient age is below 40 and high activity level, tenodesis of biceps tendon. If patient is more than 40 or older than 40, do tenotomy of the biceps tendon. So in older patient, we do tenodesis, tenotomy. In younger patient, we do slab repair. Multiple slab repair techniques have been previously described. Also, a wide array of implants options are available depending on the surgeon preference. Use of simple versus mattress sutures and the option for knotless fixation devices to minimize the risk of having bulky knot create symptoms post-operatively. You can see here different types of fixation. You can fix from anterior, from posterior, from both sides with simple or mattress sutures. After probing to confirm the diagnosis of the slab tear, a shaver can be used to resect unstable flabs of tissues that are deemed unbearable. Glenoid neck preparation is with a tissue elevator, rasp, and shaver. The nevisor portal is very important to deliver your shuttling. Then determination of the appropriate anchor placement depends on the predominant of region of instability regarding the superior labral biceps tendon complex. Here you can see the slab. Here you can see the slab lesion. When you probe the biceps, you push the biceps upward, and you see how the extent of the tear. Here we start with probing and detection of the slab lesion by elevation of the superior labrum to expose the bone affected, and then we do preparation of the surface by the shaver and elevation with the rasp to make the surfaces fresh, to increase the healing. And then through the nevisor portal, you shuttle by a spinal needle a shuttling suture comes from upward through the nevisor portal, and then you catch it by the ring forceps and drag it out from the anterior portal, and then the spinal needle get out. Then the anchor comes from anterior, then you tie one of the sutures of the anchor with the shuttling suture outside, and then you drag the shuttling suture out, so the suture of the anchor comes from the nevisor portal behind the long head biceps and into the labrum, the superior labrum. And then you do that in the other suture, and you catch the sutures from the nevisor portal to drag it away from the anterior portal to make your knots. We use here half hitches notches, and then you test the stability of the fixation. And then the second anchor, because it is a wide lesion, comes from the nevisor portal. The anchor comes from the nevisor portal now. A lasso to shuttle the sutures comes from the nevisor portal also, and then dragged from the anterior portal. And then you catch one of the sutures to put it in the lasso suture, and then you drag the lasso from the nevisor portal, so the sutures come from above the superior labrum. And then you make it in the second suture. Shuttle with lasso, and you drag the lasso from the anterior portal and catch the other suture of the anchor, the posterior anchor, and then drag the shuttle through the visor. Then you have two sutures behind the labrum and behind the long head of biceps. Then we tie with a knot pusher. So it is fixed from anterior and from posterior, and the knots away from the long head of the biceps. We test stability. It is very stable, and we finished. What is the complications of the slab lesion? First, post-operatively, you can find a wide range of patients with stiffness. Most common complication following a slab repair. Treatment, early passive and active assisted range of motion, pendulum exercises began from the first week post-operatively. If stiffness doesn't resolve with physical therapy, capsular release is indicated. Suprascapular nerve injury, over-drilling of the glenoid, because you are very, very, very near from the suprascapular nerve. A failed slab repair and persistent symptoms, many causes, including articular cartilage injury, hardware failure, and anchor ball out. Failure associated with age more than 36 years. Bicep stenodesis is better than doing a slab repair in this age. Thank you.